Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal Pericardial Institute of Medical Sciences. Today I am going to discuss with you an important topic, Pulsus Paradoxus. Pulsus Paradoxus is a misnomer. This is an exacerbation or exaggeration of the normal thing that is happening. That is, during inspiration, the systolic BP falls. And if the fall is more than 10 millimeters, it is called Pulsus Paradoxus. So, Pulsus Paradoxus is exaggeration of the normal response. There is a decrease in systolic BP of more than 10 millimeters of mercury. That is the definition for Pulsus Paradoxus. So here you can see during inspiration, this is the systolic BP, and during expiration, this is systolic BP. This difference, that is the Pulsus Paradoxus. Now, when you are examining Pulsus Paradoxus, you have to look for certain checklists. So let us see what are the checklists that should be kept in mind. First and foremost, the heart should be regular rhythm. If it is irregular rhythm, atrial fibrillation, the measurement will be wrong. Second, patient should be breathing quiet. There is a deep inspiration and deep expiration. It is what is happening in normal quiet respiration. Third, the BP cuff should be inflated longer than usual. You should be informed the patient when you are doing it. You focus on the BP cuff and the coraco sounds, not on the phases of respiration. So these are the things that you should keep in mind when you are doing the examining or determining the Pulsus Paradoxus. Now we look into how will you measure the Pulsus Paradoxus. This is by using the sphygmomanometer. Inflate the BP cuff until no coraco sounds are heard. So you inflate the cuff above the palpatory systolic blood pressure 20 millimeters above that, as usual. Then deflate the cuff to a pressure where coraco sounds are audible. So gradually you deflate and you will hear the coraco sounds. This is the systolic BP. The first appearance is the systolic BP in expiration. So when you are listening, you will be hearing coraco sounds for some time. Then there will not be any coraco sounds again. The coraco sounds are heard. So this time at which you get is the systolic BP. Now again you deflate the BP cuff. So further deflation is done, and coraco sound will be heard in all the heartbeat. That is, during inspiration and expiration we will be hearing. So initially you will be hearing, as I have shown you, it is during only in expiration. Then there is you are not hearing, and then again on further deflation you will see that the coraco sounds are heard in all the phases of, or continuously it is heard. So the difference between these two, that is the first appearance of coraco sounds, that is occurring in expiration. You need not look into whether inspiration or expiration, the first appearance of the coraco sound, followed by presence of coraco sounds audible in every heartbeat. The difference between these two BP is the Pulsus Paradoxus. So hope this point is clear to you. So now we look into a pulse tracing of Pulsus Paradoxus that came in the New England Journal of Medicine. So here you can see this is the phase of expiration, then expiration and inspiration. So this is the phase, and here you can see that during inspiration the BP is coming down. So BP is low. During expiration the BP is high. So this indicates the Pulsus Paradoxus. So in normal quiet breathing, what is happening to the coraco sounds? That is the first appearance of coraco sounds during part of respiratory cycle, and then there is continuous appearance of the coraco sounds throughout the beats. The difference between these two phases is the Pulsus paradoxus. So now we have understood how we will determine the Pulsus paradoxus. What is the significance of this? Pulsus paradoxus has got a sensitivity of 98% and specificity of 85%. So if you take 12 millimeter as the Pulsus paradoxus, this is the sensitivity and specificity. But most of the patients with the Pulsus paradoxus have got most of the case of cardiac tamponade has got Pulsus paradoxus of more than 20 millimeters. So this is not a specific sign for cardiac tamponade. So cardiac tamponade is one of the important conditions where you get Pulsus paradoxus. So now we'll look into what are the differential diagnoses. So Pulsus paradoxus is the most important condition is cardiac tamponade. It can occur in constrictive pericarditis and often in exacerbation of the chronic obstructive pulmonary disease and bronchial asthma. So these are things you should remember. Cardiac tamponade, we have already mentioned about the cardiac tamponade. Constrictive pericarditis, exacerbation of asthma and COPD. In right ventricular infarction, pulmonary embolism, etc., you can get rarely you can get Pulsus paradoxus. So we have discussed about the differential diagnosis. Now go into the history. This is a historic misnomer. Actually, this was described by Adolf Kussmaul, and this is a person, Adolf Kussmaul, and he described it in 1873, even before the sphygmomanometer was invented. Sphygmomanometer was invented only in 1881. So he found the changes in the pulse that is occurring in different phases of respiration. As he found that there is a phasic variation in the pulse, but the heart sounds are still audible, and this is what he mentioned as the paradoxus. That is, the heart sounds are audible even when there is no pulse or there is a significant change in the amplitude of the pulse. That is what that has been described as the Pulsus paradoxus. And remember, as I have mentioned, this was described even before the sphygmomanometer was invented. Now look into what is the mechanism behind the fall in systolic BP. Basically, there are two mechanisms. So first one is when there is a deep inspiration, radial traction occurs on the pulmonary vasculature. So the pulmonary vasculature, there is a radial traction when you are taking a deep inspiration because of the negative intrathoracic pressures. So you are taking deep breath. So what happens? The negative pressure increases. This produces traction on the pulmonary vasculature, and momentarily blood is sequestrated in the chest or lungs. This will produce a drop in the blood that is coming into the left heart. So the left heart blood flow decreases, and this decrease is equal to the decrease in the preload, and consequently the cardiac output is decreased. So what is happening? The major change occurs is on the left side of the heart. So when there is a negative intrathoracic pressure increases in the lungs, the blood is sequestrated. So blood entering the left atrium via the pulmonary vein is less. So the input coming to the left ventricle is less. So as the stroke volume decreases and cardiac output decreases. So this is the basic mechanism underlying one of the most important reason for drop of systolic blood pressure. And another thing you should keep in mind is the interdependence of the ventricles. That is, even though we are telling right ventricle and left ventricle, but remember that the septum is common. So what will happen? When during inspiration, there is negative intrathoracic pressure, as already I have mentioned. So the negative intrathoracic pressure will lead on to more blood entering the right atrium through the inferior and superior vena cava. So there is more blood entering the right atrium. So this will lead on to what will happen? More blood enter the right ventricle. This more blood entering the right ventricle will produce deviation of the septum. So there is a bulging or bowing of the septum into the left ventricle. So this will lead on to lowering of the end diastolic volume of left ventricle. So left ventricular end diastolic volume decreases because of this bulging. This will lead on to decrease in the stroke volume because the left ventricular content is less, so the stroke volume decreases. And that is the second reason. So there are mainly two reasons. One is the negative pressure occurring on the pulmonary vasculature producing sequestration of the blood, and second is the interdependence of the ventricles. That is the ventricular septum bows or bulges in the left ventricle, reducing the left ventricular output. So hope these 2 points are clear to you. Now we can see in this picture, this is the septum, and during contraction the septum will bulge into the, so here in this picture you can see the bulging of the septum into the left ventricle in a patient with a significant pericardial effusion. So the cell or cardiac tamponade is there. So we have understood the reason behind Pulsus paradoxus in cardiac tamponade. By cardiac tamponade you mean a significant content in the pericardium leading on to impairment of the diastolic filling or filling of the ventricle. So the almost similar thing occurs in constrictive pericarditis. But in constrictive pericarditis, one difference is that the negative pressure producing filling of the right ventricle is blunted because the pericardium is very thick and is adherent. So the normal drop in filling pressures is blunted. That is during inspiration, the negative intrathoracic pressure increases, and this will not produce much filling into the right atrium and right ventricle because of thickened pericardium. But remember that the pulmonary veins are extrapericardial. So whatever I have mentioned earlier, that is the sequestration of blood occurring into the pulmonary vasculature is the major contributor in constrictive pericarditis. Hope this point is clear. And two important conditions are cardiac tamponade and constrictive pericarditis. In severe pulmonary disease, what will happen? There is a heightened negative pressure inside. So the high intrathoracic negative pressure will lead on to sequestration of blood, which we have mentioned already. And also the left ventricle is contracting against this negative intrathoracic pressure during inspiration. That is the chest is expanding, there is negative pressure, and against that the left ventricle is contracting. And also this will be transferred to the aorta also. So both contributes to decrease in the systolic pressure in the aorta. So the major contributor in severe pulmonary disease like acute exacerbation of bronchial asthma and COPD is the action on the pulmonary vasculature and also the negative pressure effect on the left ventricle and aorta. So in this session, we have discussed about the concept of Pulsus paradoxus, which is a misnomer. It is an exaggeration of the normal response. That is, in quiet respiration, the systolic BP holds more than 10 millimeters of mercury. The major causes we should remember is the cardiac tamponade due to pericardial effusion. Second is the constrictive pericarditis, and third is severe obstructive airway disease (COPD), and also in acute exacerbation of bronchial asthma. We have discussed the mechanisms. Hope it was useful to you. In the next session, we will come with another topic, the pulsus alterations. Stay tuned.